So, dear friends, my today's presentation is on complex coronary intervention in advanced heart failure. So as you know, in the management algorithm for advanced heart failure, they're the foundational drugs, inotropic support, revascularization, and if the patient is unstable, then we consider short-term mechanical circulatory support with an IABP, an impeller, or an ECMO. And in case there is a recovery, then the weaning. And in case the patient is unstable and there is no recovering from advanced heart failure, then you assess the neurological and the organ function. And if it's a normal neurological function, then we continue the mechanical circulatory support and consider LVAD or heart transplant. So this is the invasive treatment sequence of the advanced heart failure with the vasopressors, with percutaneous intervention and angioplasty or a CABG, or a mitral valve repair, percutaneous with a mitra clip, or a surgical new chordae, or you consider CRT, which is a cardiac resynchronization device, if the patient has a low EF with LBBB, and consider also an intra-aortic balloon pump, an external balloon counterpulsation, or a para-aortic counterpulsation circulation. The mechanical circulatory support system with an impeller or with an ECMO or a Centrimag, and one may consider permanent LVAD or a BiVAD or an artificial heart. In certain cases of advanced heart failure, one may have to consider heart transplant. It may be isolated or with a heart-lung transplant. So I'll give you a clinical history of an 84-year-old female patient who has got diabetes, hypertension, a very frail lady, body weight 37 kilo, with CKD, advanced heart failure. EF was 10% on a cardiac MRI. She had 4 hospitalizations for acute decompensated heart failure. She had associated a peripheral arterial disease and a cardiac cachexia. We floated a Schwann-Ganz catheter, which showed a pulmonary artery pressure of 54/38 and a LV and diastolic pressure of 25. A coronary angiogram showed a triple vessel disease with long diffuse calcified disease in circumflex, ostial bifurcation, calcified diffuse in a LAD and a CT of the right coronary. We did a multi-vessel PCI, which was IVIS guided. Only 40 ml of VC-PAC was done, and we performed the case successfully with the hemodynamic support by Impella 2.5. The Impella was explanted after 6 hours of support in the ICU successfully. So in the protected PCI patient, we consider the complex coronary artery disease, the patient comorbidities, and the hemodynamic compromise. In our patient, the hemodynamic compromise with the LVF of 10%, the mean arterial pressure less than 60, LV and diastolic pressure more than 25, and pulmonary artery pressure 58/36. It was a complex coronary anatomy with calcified diffuse LAD and circumflex, ostial diffuse disease of both the circumflex and the LAD, and a bifurcation LAD with a good size diagonal, and a CTO to the RCA with a syntax score of 33. The patient was an octogenarian with comorbidities, age 84, long-standing diabetes and hypertension, associated CKD and peripheral arterial disease, and very frail patient with a body weight of 37. These are the pre-procedural hemodynamics: systolic pressure 80, diastolic 50, and LVEF 10%. She was on a single large dose vasopressor. This was on vasopressor, a blood pressure of 100/66 and a cardiac index of 1.9. And when we step up the vasopressor in the cath lab, the blood pressure was 130/65, PA pressure 37/21. And this was the initial puncture that we made in the femoral artery. She had a stent in the iliac artery, and she also had a stent in the tibial and peroneals. And she we put a pigtail catheter in the pulmonary artery through the right jugular vein, and then a pigtail catheter in the left ventricle. This pigtail was changed to an Impella device. So this is the pulmonary artery and the pigtail catheter. The this is the impeller device, which is a 2.5 impeller, and we dilated the lesion with a 1.5 balloon, but could not advance 60 megahertz IVUS, and hence had to use a rotablator 1.5 Burr. So because of the diffuse calcified nature in the circumflex, after rotablator we did a IVUS and then dilated with a 2 millimeter by 12 NC track balloon throughout the lesion. Then the stents were deployed. So this is 23 mm by 2.75, and then a 3 by 33 mm in the circumflex artery, and then post-dilated with a 3.5 balloon. So, and then the LED was attempted. So this was the LED, which was very diffusely diseased. There is also a wire in the diagonal. The whole procedure was done with an IVUS with only 40 ml of contrast material. And this is the deployment of the stent at the ostrum of the LED. The mid LED and the distal LED was stented. So the stenting, after the stenting procedure, a post-dilatation with a balloon was done. This is the right coronary artery, which had a CTO. A cardiac MRI had shown that it was a scarred area, but there was a viability in the PDP-LV. So we used a pilot 200 wire to cross the CTO and then dilated the CTO with the very tiny balloon, a 0.75 ml. And here you can see the PDP-LV. Because the area was scarred with non-viability except in the PDP-LV area, we decided not to stent the proximal circumflex, proximal right coronary artery. So the parameters at the end of the case showed a blood pressure of 102 by 76 without vasopressors. The PA pressure came down to 28 by 17, and on the Abiomed monitor of the impeller, the pressure is 124 by 83, and the cardiac index is 3.4. So these are the post-procedural hemodynamics with the PA pressure down to 40 and LVDP down to 18. LVF on the table was 15%. So the follow-up status of the patient at 1 to 3 months, LVF 20% at 1 month and now 35% at 3 months. And the NYHA class is 1, and there is a moderate improvement in the quality of life. So as we know in the PROTECT 2, there is more complete and optimal revascularization with impeller linked to improve outcome. So my take-home message today is that impeller enabled a complete revascularization in my patient who had a very low EF, who had multiple comorbidities and unstable hemodynamics, and the staging of the procedure was avoided with the impeller, saving overall cost and issues of non-adherence to follow-up procedure. We had less hypotensive events noticed during the procedure that afforded me longer balloon inflations, use of rotablator, OPN, long overlapping stents in the, with a TVD and ostial stenting. So this becomes a feasible option in patients with acute decompensated heart failure to stabilize and to perform mechanical circulatory supported revascularization if viability is established on a cardiac MRI. And with this kind of approach, the ejection fraction and hemodynamics improved in the patient. Thank you for your patient hearing.